If we now move on to our final poster, which is a case series of the use of Andexanet in Leeds Teaching Hospital, I'm particularly looking forward to hearing about this. So if I hand you over to Dr. Amany Mohamed and Dr. Mevish Ul-Haq.
Hi, thank you, Simon. Amany, you're about to share the presentation?
Yes, just 1 second. So, I don't know if people can see my screen or not.
Not yet. Yep, looks like it's happening.
So, good afternoon. Thank you very much to the organizers of the conference and to Thrombosis UK for accepting our case series as a poster and also as an oral presentation. My name is Amany Mohamed, and I'm a hematology registrar at St. James Hospital in Leeds. And together with my colleague, Dr. Mevish Ul-Haq, we will be presenting a case series of the use of Andexanet in DOAC reversal in Leeds Teaching Hospital. So I will hand on to Mevish.
Thank you. Next slide. So first of all, we're just going to talk about the background and rationale for Andexanet, including the sort of study that the results came from. We'll speak about the use in Leeds Hospital and then the methods that we use to collect the data for the patients that were giving it. And then Amany will run through the results and a summary of the cases with some areas to consider for research. So Andexanet Alfa is a specific reversal agent. It's a recombinant modified version of factor 10A, and it's catalytically inactive and it functions as a decoy protein. So it binds factor 10A inhibitors in the intravascular space. So Andexanet is given intravenously, and the dose is dependent on the DOAC, so whether it's rivaroxaban or apixaban, and the timing of the last administration. The rationale for Andexanet comes from the Annexa-4 study. So this was a single-arm study of 353 patients who were given Andexanet for a major bleed, and they presented within 18 hours of taking a DOAC. What they found was 64% of patients with an intracranial hemorrhage and 26% of patients with a GI hemorrhage received Andexanet and achieved hemostasis within 12 hours. So 82% achieved hemostasis without, whether it was spontaneous or a traumatic bleed. Next. So it gained NICE approval in May 21, but only specifically for apixaban and rivaroxaban, and only for a life-threatening or uncontrolled bleed in the GI tract. For intracranial hemorrhage, it's not currently licensed, but it can be used in a research setting. At Leeds Teaching Hospitals, we started using Andexanet at the end of January, beginning of February 22. And it's located in the A&E department, which is often the first point of call for patients presenting with a bleed. In order to dispense the medication, it needs to be discussed with a hematology registrar or a consultant. The case is discussed to see if it's appropriate, and then approval is given to administer the medication. So at the point that we started using it, we prospectively collected data to assess the effects and the use. And also because at the same time, there is a RAPIDO, which is a national audit run by Richard Bucher, assessing the effects of DOAC reversal, required data for that time point as well. So we were able to provide some data towards that audit. Next. Now, the dosing of Andexanet is dependent on the dose of the DOAC. So if you are taking a low dose of apixaban, less than 5 milligrams, or a low dose of rivaroxaban, which is less than 10 milligrams, and the last dose was given less than 8 hours ago, or unknown, then you would get the smaller bolus dose of 400 milligrams, and then an infusion dose of 480 milligrams. However, if the patient was on the higher dose of both apixaban or rivaroxaban, then they'd get the higher dose of Andexanet of 800 milligrams as a bolus and 960 milligrams as an infusion if it was taken less than 8 hours ago. But in either case, if it was taken more than 8 hours ago, then you would get the smaller dose, which is simplified, I think, in the next slide in a flow chart. So this is what we have available on our intranet. And the first step is providing hemodynamic support and hemostatic measures, which are just as important. So contacting the gastroenterologist or the surgical teams to manage the bleed, and then speaking to hematology to decide on whether or not Andexanet is appropriate, and if so, which dose should be given. So we prospectively collected data. So at Leeds, we have PPM, which is an electronic health record. We can create a separate list of patients who we've been contacted about to give advice on whether or not to reverse the DOAC. So we created a list of patients that we were given reversal advice, whether we were given Andexanet or we were given Octoplex. And then we used this list to select the patients that were given Andexanet. We created a spreadsheet tool to specifically look at demographic data such as age, gender, the indications for the treatment, the comorbidities, so specifically looking at congestive heart failure and renal impairment, whether or not DOAC levels were taken at presentation. This isn't sort of local practice, but some clinicians do advise it. We then looked at post-reversal blood parameters, so the full blood count, the renal function, and the liver function test, whether or not patients survived and at certain time points, so at 7 days, 28 days, and at 3 months, and whether or not anticoagulation was restarted, and if so, at what point.
So I think I'll take it from there. Thank you, Mevish. So the results, we collected lots of data. As you can see, we did the baseline characteristics. We had 10 patients who received Andexanet during the assessment period, so until November 2022. The mean age was 82.2 years of age. Most of the patients were receiving an apixaban, so 70% of them, compared to only 3 patients were receiving rivaroxaban. Most of the patients were anticoagulated because of AF, so 80% of patients compared to only 20% who were anticoagulated because of a prior thrombosis. We also collected some data on baseline EGFR, and out of 10 patients, only 1 had an EGFR less than 30. 3 patients had an EGFR between 30 to 60, and 6 patients, or the majority, had an EGFR more than 60. Only 50% of the patients had DOAC levels measured at baseline, and DOAC was restarted in 5 patients. And I think it is important to say here that most of these patients, or nearly almost all of them, were managed under other teams. So the decision to restart the DOAC was not mainly by the hematologist. 1 patient was restarted on a DOAC less than 24 hours from a reversal, 2 patients between 24 hours and 7 days, and 2 patients more than 7 days. Out of the other data we also collected, we collected some data on full blood count, and 7 patients who had blood tests done at 7 days were still anemic, so all of them. 1 patient had deranged liver function tests, and 1 patient had a transient AKI, so deranged renal function test, within 7 days. The total length of hospital stay ranged between 3 to 78 days. I'm going here to talk about survival outcomes. As Mevish previously mentioned, we assessed 3 time points, so at 7 days, 28 days, and 3 months. Unfortunately, 2 patients passed away at less than 7 days. Additionally, 1 patient passed away at less than 28 days, and the 4th patient passed away at less than 3 months. So we wanted to know what was going on, and we started to explore a bit further about the survival outcomes and also the complications. So we had 10 patients who developed a possible thrombotic event. We had 10 patients in total, but only 3 of which developed a possible thrombotic event following the infusion. We started exploring a bit more to know if there are any common risk factors that led to these possible thrombotic events. So I'm going to talk a bit more about these patients. The first patient had some clinical signs of a cerebrovascular stroke, had a CT head which showed a previous established infarct. The second patient was in a peri-arrest situation, even prior to andexanate infusion. This patient underwent a CT angiography, and this was mainly to detect the source of bleeding, and it showed incidental splenic and renal infarcts, and also developed clinical signs of a CVA a few hours later. And the third patient also had a CT head showing an acute right MCA infarct following the infusion. So to analyze these a bit further, I think it was very difficult to say what was the contributing factor to development of these possible thrombotic events. Because as you can see, out of the 3 patients who developed these possible thrombotic events, they were all female patients over the age of 85. So they were all very elderly population. They were all also on apixaban for AF. They all had multiple comorbidities. So the 3 of them had a history of congestive heart failure or ischemic heart disease. But also additionally, 2 of the patients had COPD, 1 patient had a chest infection, 1 patient had COVID, 2 patients had diabetes. So many other comorbidities in an elderly population already, and all of them were presenting with hemodynamic instability or a peri-arrest situation. And the 3 patients unfortunately died within the first 28 days. I'm just going to talk a bit further on these results, because we only had 10 patients. And as you can see, it is difficult to say whether the andexanate was contributing to these thrombotic events, or whether it was the whole situation of the comorbidities, the peri-arrest situation, that could have also contributed to that, especially if the patients were presenting with a high RUCAL score already. So there was going to be a higher incidence of mortality even without reversal. And I think in this context, we would like to say that it is something that needs to be explored a bit further. And that is what's happening at the moment with the National Rapido study, which is currently comparing also the andexanate with other reversal agents as octaplex and periplex to see what exactly are the complications or the thrombotic risk in this context. So to summarize, in patients with life-threatening gastrointestinal hemorrhage, the Andexanet Alfa was still associated with an 80% survival rate at 7 days. There might be an increased risk of thrombosis when Andexanet was used in an elderly population with a history of AF and cardiac dysfunction. However, this needs further research due to the presence of the co-founding factors, and also it needs a larger scale studies for accurate assessment rather than a case series. And the future research considerations, so larger scale studies to assess the effects of Andexanate, which is currently the National Rapido audit, further research to assess the thrombotic risks, the long-term effects and mortality rate, and also maybe audits to look at dosing regimens, time from bleeding to administration of the andexanate, the anti-10A levels, and the concomitant antiplatelet therapy and other comorbidities. So thank you. And any questions?
Thank you very much, Amany and Mevish. Happy to take any questions if you want to put them on the chat or Q&A. I suppose the thing that struck me when we saw the mean age was, you know, maybe we shouldn't be giving it to some of the DOACs to some of these elderly people. I mean, we got that signal when we first started using them in New Zealand and Japan. And we know for AF, if you've got 2 risk factors, say renal impairment and your age is over 80, we drop the dose. So I'm just thinking about the, you know, the major hemorrhage, the cost of the andexanet. Is there a case for saying, you know, 85 years and over, you just don't get this stuff? How many of you, you know, how many of your elderly patients made up that that group of patients who bled there?
I think the mean age, yes, it was higher, so it was an elderly population, and I think it is a valid point, to be honest, that elderly population, in addition to the comorbidities, and as you've mentioned, the major hemorrhage protocol, so other risk factors as well. I think it is a valid area for future research, for future considerations, because most of the patients, yes, they were within this elderly population.
Just looking to see if we've got any comments from anyone else. So actually, time is, oh, here we go. Do we know if the data you presented is representative of the experience of other trusts or from information from the Rapido trial?
So we don't have information from other trusts as such, but the data from the Rapido trial, which has been presented at BSH last week, so that had about 900 patients across the UK that had received reversal agents for DOAC-related hemorrhages. Now, the time point that it collected data was just about when Andexanet was licensed, so only up to about February 22. So they had 50 patients on Andexanet and about 730 who had received PCC, so either octaplex or beriplex. And their mortality rate was already 41%. So I think what it shows is that with current practice, there is already a high mortality risk associated with DOAC-related bleeds. Rapido hasn't published a sub-analysis to see were they more in the Andexanet group or the octaplex group, you know, whether the thrombosis was in the Andexanet group or yet. But they are collecting data again. So we've got another collection date later this year, which will capture more data on Andexanet use. So I think it'll be really interesting to watch out for that in the next 12 months.
Okay, thank you very much. I think now we are just coming up to 4 minutes past 3. So if I could just thank you both, Amany and Mevish, for an excellent talk. I really enjoyed that. And look forward to seeing, you know, more data coming from the Rapido trial.